Good evening, ladies and gentlemen. I have the pleasure to be among you in the Stroke Conference. And my lecture today will be on the issue of stroke prevention. I will cover mainly the secondary stroke prevention. And I was asked to cover the stroke prevention without the large artery disease and the cardioembolic disease, as some of my colleagues will cover also in the conference. So this is my disclosure. Of course, we will not debate that patients who had stroke are at higher risk of stroke than those who didn't have before. So this is not something, I think, a matter of debate. And also in the meantime, the burden and the problems that will happen to the patient himself, to his family, and to the society, and to the economy because of the recurrence of this stroke. So the secondary prevention means that I will prevent stroke in a patient who already had a stroke or a TIA, because transient ischemic attacks at one point, maybe like decades ago, was not considered like secondary prevention when I prevent, but now this patient had a vascular event, so he's considered exactly like the patient with stroke. And of course, to be able to prevent these strokes from coming back, we will have to use a strategy of many things like modification of lifestyles, risk factor control, and medications. And to be able to do this on the best evidence that we have, that's when the guidelines come. And these treatment recommendations and diagnostic recommendations, they are updated regularly, and we have to be following them to know where we stand today and what is the best practice that we can offer to our patients and to the healthcare systems. If we try to make it as easy as possible, I think that it's very simple, the strategy of prevention. It mainly depends on the risk factor control and lifestyle modification, medical treatments, and other interventions that we may need, like for instance, the endarterectomy, left atrium appendage closure, PFO closure, anything that's beyond the medical treatment. Of course, we usually look to the medical treatment, which is the main part that the research focuses on. So we will be maybe talking a little about this, but it is the main focus of the secondary stroke prevention. But we should not forget about the risk factor control and lifestyle modification, because medical treatments are not magic. They just complete the process of protection after the risk factor control and lifestyle modification. We are lucky this year that we had two of the major guidelines published, one by the American Stroke Association about the stroke prevention, and the second is the European Stroke Organizations. They are the biggest bodies that publish these guidelines, and most centers use them in the clinical practice. And this year, they are usually the best, I think, that I have seen because of the details written in and the updates that we will see and the impact of these changes on our practice. First thing, we will talk about the evaluation. What if a patient got TIA and or a stroke? When should we evaluate this patient? Can we wait, or just immediately should we proceed? The most important thing that he should be reviewed, the patient with the TIA should be reviewed within 24 hours by a specialist. A specialist means a stroke neurologist. It's not just a GP, not just a family doctor, not just a regular or general stroke. He has to be reviewed by a stroke neurologist who is specialized in these cases and knows how to proceed in the investigation to avoid any problems that can happen, preventing the strokes actually. So what are the kind of tests that we will need to do? Of course, we will go through some of the things that we usually do to these patients and know when to do them and what to do. Of course, any patient will have to do an ECG. This is a basic thing because we are always looking for the atrial fibrillation and the embolic strokes, which is really a cause of major strokes and major disabilities. So ECG is a very simple thing to do in the beginning of the stroke or the TIA, and we should do it. Not doing it is really a problem, and we see here that It's the level of evidence is high, and the recommendation has the best evidence. So when it should be followed, it means that it's not an option, it should be followed. And also not to delay the evaluation of the patient more than 48 hours, but he should be at maximum within 48 hours reviewed, so that things are really fast done, because the risk of strokes are usually high when within the first few days of the stroke, especially the 48 hours up to 7 days following the TIA. There's a very high risk for these patients to get another stroke, or get like we say, a major stroke even after a TIA. So there's no guarantee what will happen at this moment. So of course, it's important to know also that we are screening all patients for any vascular problems like stenosis. So any patient with TIA or stroke should get his vascular imaging, not just go and do a regular CT or an MRI. I think even vascular imaging is prior to the regular studies. So we have many options like the transcranial and extracranial duplex sonography. You have the CT angiography and the magnetic resonance angiography to screen for this. Of course, blood tests are also very important. Patients not reporting that they are diabetic or having high lipid profile, they should be screened for that immediately, because they need to be defined. And also this has a high standard of evidence. So you should follow this. So patients will do ECG, will do labs, will do vascular imaging, and should be reviewed by a stroke neurologist in a very short time. So when it comes to the PFO, sometimes in patients who had recurrent strokes, maybe like the cryptogenic strokes or the ESUS, we sometimes feel that there's something hidden in the patient, and we can screen these patients using the TCD with a special technique to be able to know if there is a PFO, and also define the risk, because not all PFOs are risks for strokes and should be closed, but some of them. When it comes to the medical treatment, I think this is the most important part of the lecture, although we will not say much, but it's the most important or the most attracting part, because there is updates in the medical treatment. Of course, first thing is the regular thing that we would think, that not to use oral anticoagulation when antiplatelets are indicated. Antiplatelets is the main treatment and the basic treatment of the prevention of stroke, except if the patient has a cardioembolic source or another indication for oral anticoagulation. Because so if it's a non-cardioembolic stroke or TIA, then antiplatelets is the indication. Because now we see some practices giving a combination of NOACs with the antiplatelets like aspirin empirically for these patients, and this is not a right thing to do. So anticoagulations are only given when indicated, but in the regular setting of a non-cardioembolic, we still give the antiplatelet. What kinds of antiplatelets do we give at this stage? We give as a single antiplatelet, like the aspirin and the clopidogrel. The aspirin dose is within 50 to 225 milligrams. Clopidogrel is 75 milligrams, or a combination of the aspirin extended release dipyridamole twice daily for the secondary prevention. So these when we use a single. But now we have a new update about using of the double antiplatelet therapy in these patients, which is the minor stroke. We usually do not give this combination in the start of the large artery strokes, and many trials have shown that these increases the risk of hemorrhagic transformation and frank hemorrhages inside these strokes, and can increase the mortality. But now when it comes to minor strokes with NIH maybe like less than or equal 3, and non-cardioembolic, again, we should be aware about this, or a high risk TIA with an ABCD2 score more than or equal 4, we can give the aspirin plus clopidogrel for prevention for the time between 21 to 90 days. It can start within 12 to 24 hours of symptoms onset and last for 7 days, at least 7 days from the onset, and up to 90 days. And then maybe we should not continue on this and revise again the diagnosis and see if we need or not. But now the newcomer it's the ticagrelor. After many trials that have shown maybe higher risks of hemorrhages when used in general strokes, but with the meta-analysis and new trials, we have seen that when it comes to minor strokes, ticagrelor can be used with aspirin for 30 days. Of course, here the patients has to be a high-risk patients, like they have an extra or intracranial stenosis of more than 30%. We can use them for 30 days, but after that we use the single antiplatelet. Some also other event, but of course we can see that the level of evidence here is not the same as we see with the aspirin clopidogrel. It's a new thing that we should use and then update maybe the guidelines later. But this is big because ticagrelor is a new addition to the treatments that we can use for minor strokes, and also increasing the dose of the already used antiplatelet or changing it to another platelet is still not clear. If I have a patient with aspirin on 75 milligrams, increasing them to 300 milligrams may not be really the thing to prevent. So we should consider the risk factors and see what's the best treatment to give. Also, giving the dual antiplatelets for more than 90 days is not advised. And also another practice that should not be done is using the triple antiplatelet therapy. Some urologists, they give this off-label, giving 3 antiplatelets, and this will markedly increase the risk of hemorrhage without really decreasing the risk of stroke. But the side effects like the hemorrhage will increase markedly. And this is a simple scheme by the American Heart Association, American Stroke Association, when stroke or TIA, when it's a high risk minor stroke, so we can give the dual antiplatelet, and the same in the stroke. But when it's not really a high risk TIA or stroke, so we usually give the single antiplatelet when it's a large stroke or not a high risk TIA. We can give a single antiplatelet. But this dual antiplatelet thing is, I think it's the main update in the guidelines. Again, the ESO guidelines also said the same about, with a strong recommendation of using the dual antiplatelet for 21 days for aspirin and clopidogrel, and a recommendation not as strong as the aspirin clopidogrel for the ticagrelor, but it also put a high risk of patients with intracranial stenosis or the symptomatic stenosis in the ICE extracranially of 50 or more. So not every patient will get this, but this is a new addition in the treatment. But when it comes to small vessel disease, the use of cilostazol for secondary prevention is still uncertain. And of course, cilostazol is a drug that had many debates because of its trial mainly on the Asian populations and the combinations in the intracranial stenosis, but still it's an option to use within the guidelines. But for the new addition in the new American Stroke Association guidelines is that it's not really uncertain if it can be good for the small artery disease, not for any stroke, but for the intracranial stenosis, it's something else. This is the medical treatment and the updates that we got in the medical treatments, but we should not forget that we give patients medical treatment, but what if the patient has his blood pressure or blood sugar not really controlled? So what will really happen to this patient? We usually see patients getting double antiplatelets and coming to us with recurrent strokes despite getting these best medical guidelines treatments like aspirin and clopidogrel. So how could a patient on a double antiplatelet get new strokes? So now we should be aware that we should control risk factors and lifestyle because they are the major risk factors and cause. We will not get prevention of stroke without control of the risk factors and lifestyle modification. And in my opinion, this comes before the medical treatment. So before prescribing the medical treatment to the patient, we should advise him and give him the counseling he needs in any problem with the risk factor control, and refer him to specialists and special services for stroke patients to help him get these things under control fast. Of course, these are really logic things. Of course, we look at the LDL cholesterol because this is the target, not just the total cholesterol, but the LDL cholesterol above 100 milligram per deciliter is not okay. And we should reduce it using the atorvastatin, like 80 milligrams, with a target of less than 70. We should maybe follow it. This is a high evidence that we should follow. And now what happens is that some patients get the triglycerides or the lipids still high despite giving these treatments. So now there are new classes of treatments that has been added, like the PCSK9 inhibitor therapy and the IPE2 treatment. So these are new classes of treatments, maybe added to the guidelines. Of course, they are not on the same strength of evidence as the statins, but they are things to add or to combine or to give when hyperlipidemia needed to be more and more controlled. And of course, a simple and logic thing is the low-fat diet and low alcohol and increasing of the omega-3 is something we need along the treatment. So when it comes to diabetes mellitus, of course, diabetes is a major risk factor. So we have to follow the hemoglobin A1C, having it at 7% or less. And of course, using the the glucose lowering agents will help to reduce. And this is usually not done by the neurologist, but the neurologist should be following that the patient is getting his service, meaning that I will review his hemoglobin A1C, and if I find that it's not optimal, I will send him to the diabetologist. And of course, the lifestyle modification in terms of diet and exercise for diabetes patients can help a lot. Obstructive sleep apnea is a long forgotten problem in the risk factors and management of stroke. So we usually don't remember it all the time, and we don't really give enough attention to it, but it is a risk factor for stroke. And we should ask our patients about it and do the diagnostic tests if we need it. And if the patient needs the positive airway pressure, he should use it to decrease the risk. Of course, with the improvement of the lifestyle and the weight reduction and some exercise, but this is a problem that we should not, as stroke neurologists, forget that it can be a risk factor for stroke, especially in obese and overweight patients. Of course, the hypertension is not covered in my lectures because some of my colleagues will also cover it in their lectures. And as you see, I did not also comment on the large vessel occlusion and the cardioembolic because my colleagues will cover it in the conference. Smoking is one of the major problems that is a major risk factor for stroke that we see. And it really needs help because the patient usually we all listen to the words like, I cannot stop it. It's really a problem for me. The patient saying that no matter what happens, I will not stop smoking. So there's the psychological part about the smoking that needs support. So these patients need counseling, and they may need treatments to stop the smoking, and they need to stop it as fast as possible. And if unable, then at least they should get help to decrease the smoking until they stop it. And of course, even if he's not smoking, so what if he's working in a place or someone in the home is smoking? This is passive smoking, which is almost as dangerous as the smoking itself. So patients should avoid passive smoking, not sitting in places or with someone who's regularly smoking. This is very, very important. But the counseling is very important for these patients because we just tell them in the clinics, please stop smoking. But he may not be able to stop it himself. We will have to refer him to special clinics, and he might need psychiatric assistance, medical treatments to stop the smoking. Obesity is a real problem, and I think it's all over the world. Maybe in our region also we suffer from this problem. So weight loss is very important, and he might also, the patient will need support, like telling the patient to lose weight, but not giving him a way or a roadmap to do this, so he will not lose weight. This is a thing about lifestyle. He's been like that for some time. So it's not easy usually to lose weight, but we need the patient to lose weight and to follow the body mass index regularly to be able to know if the patient will decrease the risk through the decrease of the obesity. Physical activity is a problem, and I think in the MENA region we suffer this problem because our population are not really into the physical activity like going to the gym or doing aerobics. So this is a problem. So the physical activity is very, very important. So of course, the recommendations about aerobic activity for at least 10 minutes 4 times a week, or a vigorous intensity aerobic activity for at least 20 minutes twice a week. If this is not feasible, we can do this up to walking maybe. but at least we should advise our patients about the physical activity, not staying at home for hours without walking or moving around. So physical activity is also important. Substance abuse, of course, is a problem, and it's rising all the time. And we see this with young patients getting strokes. We should be aware of that. We should ask about that. And also, this will need professional support, whether it's for alcohol, for stimulants like amphetamines, like cocaine or khat, or for any substance abuse like drug or alcohols. There should be specialized services for these patients. And as we see that stroke care is not just giving thrombolytic therapy and thrombolysis and sending the patient to a rehab center. No, there's a lot to do about these risk factors and lifestyle modifications through specialized clinics and services that could help these patients, because all of the work that we do, like we have a patient that he did thrombolysis, thrombectomy, and he went fine at home and he's getting his medical treatment, but he's not controlling his risk factors or his risk factors or the lifestyle modifications. Then despite all that, we will lose all the effort that we have done and he will get another stroke. Diet is, of course, important. What is called the Mediterranean type diet, which is full of monounsaturated fat and plant-based food and fish consumption. Although this is a bit funny because I live in a Mediterranean country and I know well how food can be really, really harmful because of the fat and things in Egypt. Maybe we see this, but there is a Mediterranean type diet that we should follow. And the sodium intake is also important to reduce, especially in hypertensive patients, but this is important for our patients. Here, if you look at this schema by Diener, it's very good because it puts everything like in one shot, but it starts first with the lifestyle modification, if you see, then the hypertension, lipid, and risk factor control, and then the antiplatelet therapy, and then other conditions like the embolic, the patent foramen ovale, symptomatic. These are interventions that we have seen. So we should not forget about the lifestyle modification and hypertension and lipids. The control of these things is really important before even going into the selection of the antiplatelet treatment. Also, a good thing, a very beautiful checklist that I have seen developed by the American Stroke Association for the stroke neurologists discharging the patients and revising them. And in stroke clinics, it's really helpful to be able to make sure that we did not forget anything. If we see here, we can see the sleep apnea. So we sometimes stroke neurologists, especially young neurologists, they miss these things. So these checklists are very helpful in specialized centers for not forgetting any important thing. So if I'm really going to highlight the change, of course, all of the things that we have talked about are really there from a long time in the guidelines, maybe just adding new classes, but the main update that will really, I think, in these guidelines will really help us in our practice now. It's the dual antiplatelet for the minor stroke for the TIA and the addition for the TICA Grelor in the guidelines. So I think this is a major change. This is very important for us. And I think that we will be collecting the data on using these drugs for the future, especially looking at the safety first. But if it can improve the practice, I think this is a big change that we have seen. And it's not just in one guideline, it's in the American Stroke Association and the ESO, which are actually the biggest bodies that publish these guidelines. And at the end, I thank you very much, and I'm really happy to be among you in the Men Stroke, and wishing all of our colleagues and patients the good health and prosperity. And thank you very much.